All right. Everyone can hear me okay? And the pointer works? Yes? No? Does the pointer, we're good? Or yes. Okay. Okay. All right. So like Dr. Williams said, really a lot of these topics have been new. So this one is a new lecture for me. And while I was preparing it, I actually learned a whole lot. And kind of right before we get started. So I think it's really important to know why we're doing this. Earlier this year, we had a course directors meeting. And really, we got some information that, in particular, communications and interpersonal skills is becoming increasingly important on your step one. And these are multiple choice questions related to communication skills, which sometimes is definitely, I think, a little difficult when you're studying because you're like, well, communication skills, it should be pretty obvious. But some of those questions can be a little bit tricky. And we have not been performing up to the average compared to the rest of the nation in terms of communication and interpersonal skills. And so we were trying to look early on at what we needed to do. So just as you all keep this in mind when you're studying, take the time to go over those communication questions when, you're studying on UWorld and all of those types of things. But they make up 6 to 9% of the content questions and 6 to 9% of physician task competency specifications on step one. And this is really all the content in terms of communication. Oh, no, there it goes. Which one's the pointer? Oh, right here. Yeah. So patient interviewing, consultation, interactions with families are the majority of this. And this is just, fostering relationships, information gathering, information provision, and making decisions, supporting their emotions, enabling patient behaviors, and then use of an interpreter or surrogate. So when I was developing this lecture, I was going to kind of do a hodgepodge of things, and then partially because we wanted to present the award, and partially because I started to spend a lot of time on interpreter or surrogate use, I was like, oh, wow. I think really taking the time to focus on how do we use an interpreter if you're in a clinical situation, what are some tips and tricks to be able to do so, and what are really the guidelines to do it? Because, when I was a medical student, I didn't learn this formally and kind of had to learn it. And so hopefully you all find this insightful and you gain a lot of knowledge. And like Dr. Williams said, please give me feedback on this so I can make it better for the next time, for next year as we move forward, okay? So our objectives today, we're going to define limited English proficiency and identify related healthcare disparities to this. Identify the importance of using an interpreter when necessary, including who can translate and why they are necessary, and then to determine the best steps in enhancing the care of a patient through the use of an interpreter. So what is limited English proficiency? So for most of us in the United States, unless we somehow have an illness when we're traveling out of the United States, we have a terrible accident, most of the time we're still going to be able to speak English even in a lot of foreign countries. English-speaking patients, we've never had to really express concerns to someone who didn't speak their language because a lot of the time we're speaking English. From about 2010 to 2015, 62 million people born in the U.S. or another country spoke a language other than English at home, which I think is important. And 41% of these individuals have limited English proficiency, which is defined as an individual older than the age of 5 who speaks English less than very well, okay? So that's a large percent of people that have limited English proficiency. Hearing loss in the United States, 15% of those in the U.S. over the age of 18 have some form of hearing loss. This usually occurs between 60 to 69 years of age and proceeds after that specifically. 90% of deaf children are actually born to hearing parents, which I think is important, particularly when you're on your pediatric rotations and when you're taking care of peds, to keep that in mind, that most of the time, if you're speaking to the parents, both of them are able to hear, but the child may not, so you need to keep that in mind when you're trying to talk to the child. And 28.8 million adults could benefit from the use of hearing aids. Does that many use hearing aids? No. I tend to think about my grandma in particular. She has hearing aids. She often does not use them, and the TV's blasting at 90 when I come in to see her if I visit her ever. So just keep that in mind when you're taking care of your patients, okay? So there are a lot of healthcare disparities for those with limited English proficiency. And I think that this is really where this comes in mind and why it's so important to be using an interpreter as we go through this lecture. It's been shown that they have an increased length of hospital stay when there is no interpreter used at admission or discharge, just because we're not able to communicate in the appropriate way. For the majority of medical errors that happen, it happens on admission. It happens when we're taking that initial intake and we're taking that medication history and we don't know what the patient's meds are, so that's why it starts right at that point. These patients actually have a greater risk of line infections, surgical infections, falls, pressure ulcers, and those with limited English proficiency compared to English-speaking patients. They have an increase in risk of delay in surgery or readmission due to difficulty understanding directions. So, I mean, if you think about it, if you can't explain the risks and benefits to a procedure because there is a barrier to your communication, then this is potentially going to delay the procedure. It's going to, if you don't give them the appropriate discharge instructions, they're going to come back and they may come back to the hospital because they didn't understand what they were supposed to do. And with that, there's a greater chance as well of readmission for chronic conditions among racial and ethnic minorities compared to their white counterparts. And so that also may have to do specifically with their limited English proficiency. Okay. So some of the causes of adverse events related to this, a lot of times we're using family and friends and non-qualified staff to provide interpretation, which we're going to talk a little bit more about in the coming slides. We use, as doctors, we may say, well, I have a Spanish minor, so I could say, well, I've got a little bit of English, so I have a little bit of Spanish knowledge. I may be able to get by in the patient encounter because I can ask some basic questions. As well as, the culture, beliefs, and traditions that may affect patient care related to minimizing pain, deferring authority, or gender roles which may affect the patient care, are just an example of a few of them, okay? So federal guidelines, this is where really everything started. In 2000, Title VI of the Civil Rights Act of 1964 required federal agencies to develop systems to improve access to their programs and services for persons with limited English proficiency, defined as those whose primary language for communication is not English and who have a limited ability to read, write, speak, or understand English, okay? And then in 2003, the Department of Health and Human Resources provided guidelines on how to do this. And they required language assistance services that had to be free for patients, accurate and timely, protect patient confidentiality, and be provided by qualified interpreters, okay? Let's see here. And a little bit more detail specifically as well. The ADA also has guidelines specifically for deaf patients that go along the same lines, that you have to have an interpreter available for these patients. We're going to talk a little bit more about some state regulation too, which is a lot more sparse and just kind of all over the place. I spent some time, my husband is an attorney, and I was just talking to him about this lecture, and he started to look over state guidelines for West Virginia when I was just talking about giving this lecture, and then actually reached out to the hospital as well to see what they said. So we'll talk a little bit about that at the end. So case number one, a 72-year-old female that presents to clinic for establishment of care. She recently moved from Mexico to the United States and understands a little English, but primarily speaks Spanish. She's accompanied by her adult son to the appointment, who is fluent in both English and Spanish. Which of the following is the best way to proceed with a patient interview? A, ask your staff to reschedule with another provider since you're unable to understand her well. B, continue with the interview having the son help to interpret all communication. C, continue the interview as you have some Spanish-speaking skills and she understands some English. Or D, contact the institutional translator to assist in the patient interview. Any thoughts on this question? Show of hands, anybody think it's A? Okay, no A's. How about B? No? Okay, how about C? Anybody? How about D? All right, everyone's picking D. which is, we'll get back to that. So why do we use a translator? First of all, we want to translate the language for both the patient family and for the provider, right? We want to make it as simple to communicate as possible. And that sounds, it sounds really simple, but at the time when it's happening, it's a lot of times a lot more frustrating on both sides because that already is complicating your basic patient interaction because there's a limited barrier to the language. Also, we use a translator for clarification. Maybe there's something that we can't understand or something's not directly translatable to English, or there needs to be a little bit more clarification of the information. A translator can function as a cultural liaison as well to help understand cultural beliefs about illnesses, causes, or care, which I also think is extremely important because just cultures have, we have different ways of providing care and understanding care when it comes to a variety of different things, so we can use the translator for that, as well as act as a patient advocate to understand barriers to a care, appropriate follow-ups, and instructions. So it's not just sometimes, we're communicating just to understand the information, but it's really helping to provide that care to the patient, okay? Benefits to using an interpreter: we reduce errors in communication specifically. It improves patient satisfaction, all right? Which I think is really important, and that leads to lower malpractice rates as well, which I know that's something that as healthcare providers a lot of times we're fearful of, but what we just need to do is make sure that we're meeting the standards for the patients that we need, and that shouldn't be as much of an issue. It reduces hospital length of stay and readmission rates, kind of as I already had mentioned, and then it meets the legal requirements that are given by the federal government as well, okay? So who can actually, the question here is, can act as an interpreter during the patient encounter? An institutionally trained interpreter, a healthcare professional that is fluent in the patient's language, an adult family member, a child family member, an untrained interpreter, institutional, or the first pretty much three, or all of the above. What do y'all think the answer is here? Okay. All right, who thinks an institutionally trained interpreter can act as an interpreter? Raise your hands. All right, everyone feels pretty good about that. How about a healthcare professional that's fluent? Yeah, see a fair amount of shaking hands. How about an adult family member? Some kind of do. I see a little bit of like, maybe. How about a child family member? See some no's, okay. And an untrained interpreter. Probably shouldn't be, right? Though probably happens a little more than it should in actual practice. And so, yeah, pretty much the answer here is F. And we'll kind of go over each one of these specifically here. So who can translate? Institutional translators are trained professionals in providing interpretation, okay? Here at WVU, we have a video service that allows for this. This is for patients that are deaf. This is for patients with limited English proficiency. We pretty much have access to, a majority of languages. I've used a couple myself. There's also a lot of times phone services or in-person translators that might be available. The unfortunate thing is that a lot of times at smaller institutions, rural areas, other places, you may not actually have access to this, and so that's something to keep in mind. I think now that we have, obviously the internet has done wonders, and so you have access to things that cross by using just internet access, but it's been something that's previously been pretty limited. Multilingual healthcare professionals can and should be trained to be able to interpret medical services and to do this before, just providing the care. But it's actually been shown that fluent language healthcare providers are not inferior to institutional translators. So if you're fluent in Spanish and you can talk to that patient in Spanish because of your fluent, as long as you're trained, you should be able to provide that care because it's going to be equivalent to using an institutional translator. Family members or friends. So sometimes you might be in a situation where you don't have access to an institutional translator or you don't speak, the language very well, but the children insist on translating. Young children should never translate. pretty much because they don't understand adult healthcare problems, okay? And a lot of states actually have rules against this. West Virginia does not. There are pretty limited state laws in West Virginia, actually, as I took the time to look into this, about translators, aside from in the court system and determining decision-making capacity. Specifically for patients that are deaf, we don't really have any state laws regarding the limitations for who should or who should not be helping to translate, which I found pretty interesting as I was researching that. But adult children may insist on translating, and if they do, usually I think what's important is to explain why that it's so important for us to use the institutional translator. And if they're insistent, then you just have to document this in the patient's chart. Say, you know what, the discussion about using a translator was discussed, but, so-and-so felt that they could translate. And so as long as you document that, then that's okay. Untrained translators are anyone that is untrained. So friends, families, healthcare providers that don't actually understand the system to doing it. As a provider, the thing is that you're unsure of how effective your thoughts or questions are being translated. So this may cause you to lose a lot of control during that interview and kind of, get away from you. You may not be able to actually give the information that the patient and the family need because of that. Like I said, young children should never be interpreters due to lack of knowledge of adult medical problems. So someone comes in with their 15-year-old child, you need to say, you know what, we'll be right back. I'm going to go get the translator. We'll come back in and do this. Sometimes family or friends may have their own personal agendas. And so it's really important to not have any, personal biases regardless of who you are when you come in and to take care of your family member. And you want to make sure that you have someone that is, just there to interpret at that point. So then that way we can address the needs for the patient that's right in front of us, who is the most important person in that setting. Sometimes you may get unsolicited advice given by an interpreter when it's not appropriate in that setting just based on the training. There may be some difficulty with medical terms or maybe embarrassment of questions. Think taking a social history sometimes is already hard, right? It's already a little uncomfortable. And then if you can't ask those questions in a safe space because of the embarrassment related to doing that and using an untrained interpreter such as a family member, that may cause some more problems. It's often easier as providers for us to ask questions in a different language and not to give answers. So that's not really going to help the patient if, we're untrained in doing it. Like I've already mentioned, it leads to substandard care, and specifically the use of non-professional interpreters lead to longer hospital stays and increased admission rates. Okay. So kind of back to case number 1, everyone was right on there to use that contact the institutional translator to assist. That is your single best answer there, okay? Could you use the son who speaks Spanish? Absolutely you could, but that is not the best answer to do in that case, okay? So you obtain the video translator and enter the room. When talking to her and using the translator, which of the following is the best way to proceed? A, use humor throughout the encounter to help establish rapport. B, speak to the translator directly. C, avoid use of she said or tell her. And D, speak in long sentences. Any thoughts on this question? Which one's the best answer here? C. Okay. All right. So preparing for the encounters before you go in. Really, these next few slides are going to be what you think about when you go in to see a patient, okay? So first, you want to identify any patients that need a translator, all right? That's probably the most important step right when you start. If you don't know and you go into a room and you realize that, someone does not speak the same language as you, just, tell them that you'll come right back, get the translator, and then go back in. You want to try to meet with the translator before an encounter, just to identify some of the background information of the patient as well as what the goals are. Maybe today, you're going to be talking about what we're going to do to manage their blood pressure. maybe a pathology report has come back and you're going to be having a really tough discussion about, a new cancer diagnosis. So if you can beforehand, talking with the interpreter about what your goals are, so everyone's in the know first, might be helpful. You also want to try to request extended time for the encounter if a translator is necessary, only because, sometimes you're going to have technical difficulties. It may take a little bit longer to go back and forth with the patient. And so trying to keep that in mind when you know you're going to be taking care of a patient, particularly in clinic, is probably going to be more helpful. During the patient encounter, using a translator. So you always want to use sentence-by-sentence interpretation. Do not give a long, drawn-out paragraph about what's going on and then expect the interpreter to translate it specifically, directly, the exact way you said it to the patient, okay? Short sentences. Limit those key points to the patient in 3 or fewer if you can, only to make it easier for the patient to take in. Give adequate time for the interpreter to complete the translation, so don't start talking and keep talking while the translator's still finishing the information, or maybe the patient's responding, so then that way, you need to make sure that you give adequate time for that to happen. Avoid the use of any humor, jargon, acronyms, as a lot of times this gets lost in translation to other cultures, so sometimes what we think is funny is not. Also, if you are not trying to say something to the patient, don't say something under your breath or mumble it or anything like that. Keep it to yourself. I know a lot of this stuff sounds pretty easy, but then you get put into the situation and you're just like, okay, this is a little different, not quite as easy when you're put into the situation, okay? You want to place the translator to the side of the patient. I do like, sometimes they say behind it, I do like making sure that the patient can see the translator themselves too, if, maybe the translator's asking them for clarification. Any way that you can give direct eye contact and make the patient more comfortable, I think is the most important thing. You always want to speak directly to the patient. If, this is the translator and I'm talking here and you're the patient right here, make sure you're looking directly at the patient, okay? Once again, it sounds easy, but it's really easy to start turning and talking to the translator who's the one that's giving that information away, okay? Use first person and second person, I, you. Don't say he or she, they, or anything like that. You want to treat them for the person that's directly in front of them, or directly in front of you, not to the interpreter, okay? Speak in short sentences, short thought groups, making it easier for that translation, and ask one question at a time, okay? Any questions so far on the patient encounter at all? Yeah. Mm-hmm. Okay, so the question is, where is that line when using a patient, family member, or friend that knows the language? That's the thing. Aside from the guidelines saying that, the federal guidelines saying that hospitals are required to provide services, there aren't great guidelines, aside from you should do your best to use a translator, period, regardless of the language. I think a lot of times, unfortunately, and you all will probably see this at some point during medical school residency or down your career, that it may be easier for you at the time to be like, well, I speak enough Spanish that I can do this, or the family member knows decently well and it's just easier. And it comes to being convenient for us as providers by doing that, and we really need to sit there, and that's when we take the time and go, are we making this easier for the patient who's right in front of us, or are we trying to make this easier for us because I still have 5 patients to see and I'm running 15 minutes behind? It's one of those things that it gets done. I'm not saying that it doesn't, but we should really try our best to use an interpreter because it's required for the service. That's a good question. Yes? So that's a good question. Question was asking about permission to need a translator. So I don't know if it's much as permission as it's knowing that there's access to a translator. Because, your patient may be fluent in English as well, even though maybe they speak more Spanish, for example, but you need to make sure that they know they have access to it, I think is the most important thing, and just ask. I don't think there's ever been a time where I just roll in with the iPad video and I'm like, all right, here we go. I may have it with me, but I may say hey, we have a translator. Are you okay if we use this? But really, when I was going back through all of this, it's more knowing the access to the available care that they have needing a translator, and a lot of times people don't know to ask. And so I think that's the most important thing, though obviously asking, because if a patient says, oh no, then I don't want that. Or if they say, no, I want my son to interpret for me, I want my daughter to interpret for me, then you've asked the patient. But I think that also by doing so in ways there may be, one, I think it's partially cultural, but also, just understanding from our side on the healthcare perspective why we think it's important. And so sometimes I just say, I think it's really important as these people are trained to take care of you, trained to help with interpretation if anything were to arise or questions. It's really beneficial for you and for me. And if they still say, no, I just want so-and-so to translate, you just say, okay, that's fine, and then you do that. And that's kind of how yeah.
So what's the best step if it's an uncommon language?
Mm-hmm. That's a very good question. So the question was, what's the next best step if it's an uncommon language, if it's a dialect that you don't know? So that's really where it's tricky. Like I said, the video translators we use have a pretty significant accessibility to a lot of languages. If that doesn't happen, then and we don't have access to it, then I would be going up and finding someone to help me, because we have to find a way to help the patient. So I would probably go first to, I don't know if I'd go to the patient advocate, probably first to be like, what resources do we have, because this is the language, this is the language that they speak, but we don't have access to that. How do we get help to find that? And that's probably what I would do. But there may be times where you get put into that tricky situation, and if you don't, and you look through all these resources and there's nothing available, and there happens to be a family member that does speak both languages, then at that point I would probably say, this is our best option available to us right now, and we're going to continue to work to find a better option, but this is what we're going to have to do for now, if that's okay. So I kind of put, patient safety comes first regardless, and if someone's crashing and we need to do something, then you got to do what you got to do. But if you have the time to try to find the access to help that patient, then that's what I would do first. It's a good question. All right. So wrapping up the encounter and the post-encounter, you want to make sure you use the teach back or show me method to ensure patient comprehension. So, so if I gave instructions on adjusting the patient's insulin, I would ask them, okay, so what are you going to do with your insulin when you leave today? Okay. And then have them teach me back or show me if, we made adjustments or that we're starting an insulin pen or something like that. Make sure that they show you how to do that or teach it back to you. Document the use of your interpreter and their name if you know it in your notes, so then that way you can always refer back to it if there's a question down the road or if something were to happen. Documentation is key for everything, so always make it easier. If your patient family insists on being a translator, then be sure to document that in your note as well, okay? So one of the last things I like to think about, what can we do to continue to improve the care for those with limited English proficiency? When I was going through this, I could have gone on and on looking at healthcare disparities related to this, but I think, there's a lot of steps that we're taking and things to keep in mind when you go to see a patient, when you're on the wards next year, wherever you go to residency and take care of patients. You always want to make sure, you foster a supportive culture for safety of the diverse patient population. And that includes those specifically with limited English proficiency, okay? You want to keep that in mind. adapt systems to better identify medical errors that occur for those with limited English proficiency. I think a lot of times when we kind of take the easier way because, we can get by with it, we may be causing more medical errors. And so it's really important to identify those errors that may occur and report those medical errors as well so we can find ways to improve their care. You want to routinely monitor patient safety of those patients with limited English proficiency, as well as address root causes to prevent medical errors for patients with limited English proficiency. Like I said, West Virginia really has some limited laws in particular, which was just something that I did not know as I was looking over it. And aside from the federal regulations given by the ADA, the Affordable Care Act, that you have to provide an interpreter, there really aren't a lot of them, particularly for West Virginia, which in ways, surprises me, but at the same time, I haven't taken care of as many patients that have limited English proficiency. I've taken care of a handful of patients that are deaf, but I think that that's just something that we need to keep in mind going forward. And, if you all are interested in, continuing and improving the care of patients at the state level, those are things to think about if this interests you. If you have more questions, please let me know. Like I said, I touched base with our legal today just because I was curious, but we don't have any specific bylaws or state laws regarding the care for patients with limited English proficiency specifically. So conclusion, limited English proficiency is defined as a person greater than 5 years of age who speaks English less than very well, okay? Healthcare disparities exist in those with limited English proficiency, and federal regulations have been placed to ensure access to translator services. A trained institutional translator or fluent healthcare professional are best to provide interpretive services, okay? There are other ones you want to avoid. Any children, particularly under the age of 18, because they don't understand the care, but you really want to try to use these. Follow the systematic approach that we kind of talked about when you're going through talking to patients and providing their care, and then look to continue to improve these healthcare disparities for those with limited English proficiency through multidisciplinary approaches. All right, and I think there's some resources. And I think with that, my lecture's finished. Are there any questions before we end? Yes? Yeah, so the question was, is there ever a time where you don't know what language they're speaking, no one's there to know? Yes, that can happen. I guarantee it. I have not had that happen to me personally, but once again, if there is a complete limit to the barrier of care because of that and there's no one around, that's when I would be going up and I would start with the patient advocate and see where I need to go to find the access and find someone that can help with that, because there are trained people to do that, but you just have to find the person to be able to take care of them. But yes, that very well could happen. So if that's it, just sit there and think, where do we go? And usually I would start with the patient advocate at that point, just because they're there to ensure that the patient's experience is better. Any other questions? Yes? Mm-hmm. So we don't have that here. I don't know if at other medical schools they do. I would have to look into that and I can let you know. But hospitals provide that specifically for training. And residency programs here, like I said, I learned about this today, so it wasn't something that I went through at the time, but I think it's partially just a lack of knowledge of knowing that you need formal training, and it's at a hospital level. Like I said, ask some questions, and I'm still getting some answers back, so when I find more answers, I'll let you know about getting the resources to do that. But if that's something that you're interested in, and you have, if you speak multiple languages and you're fluent in them, then look, ask your training, say, hey, where can I get trained to be a medical interpreter so I can be able to do this? Because I think it would be really helpful and improve the care that you provide your patients. All right. Thank you all so much. Have a good day.